Well, welcome everyone. Thank you all for joining us for our monthly OCD Massachusetts virtual lecture series. Maybe one day, we were just talking about, maybe one day we'll be back in person, but for now, I'm glad that so many of you could join us. My name is Nathaniel Van Kirk. I'm the president of OCD Massachusetts, and I have the pleasure to be joined today by Dr. Erica Greenberg from Massachusetts General Hospital. And so before I introduce Erica, one of the things that I do want to just remind everyone is that this is being recorded, but only what's kind of on the screen and Erica's presentation will be recorded, but all of our talks are uploaded to YouTube, usually within like a week or two following, so that everyone can go back. If you had questions or thoughts or want to share it with others, please feel free to check out the OCD Massachusetts YouTube channel. Additionally, on our website and on social media, we have any updates for the lecture series and things that are going on. So please feel free to follow us there. And so to get it started today, Erica, it's a pleasure to have you here with us to talk a little bit about Tourettic OCD. I know this is a topic that a lot of people have asked questions about and had interest in. And so just a little bit about an introduction so everybody gets to know you. So you're a child and adolescent psychiatrist at Massachusetts General Hospital and an assistant professor in psychiatry at Harvard Medical School. And currently you're the director of pediatric psychology, old habit, pediatric psychiatry for the OCD and tic disorders program at MGH, as well as the co-director of the MGH Tourette Association of America Center of Excellence. And you're on the medical advisory board for the Tourette Association of America. So quite busy. I really appreciate you taking time to come talk with us a little bit about your interest in kind of Tourette syndrome, OCD, Tourettic OCD. And I know you also have interest in ADHD and how body-focused repetitive behaviors sometimes overlap with these. In addition, I know it sounds like you also have a really great, you're primary investigator on a study evaluating the behavioral treatment for those with tic disorders and ADHD, which I know is probably one area we might get some questions on around the treatment, because I know it's a question that comes up a lot, especially when it comes to those repetitive behaviors, rituals, and the overlap with tics and Tourette's, and how do we tease it apart, what do we do? And so you graduated from Weill Cornell Medical College with honors, and then you completed your general psychiatry residency at Harvard down in Longwood, down where all the traffic is. So a little bit further away from the rest of us out here in Belmont. But then you also did your fellowship at MGH, where you're now chief resident for both programs, and we're happy that you continue to stay here. So we have your expertise in the Boston area with us. So Dr. Greenberg, thank you so much for joining us. And I'll hand it over to you to go ahead and get started. And then at the end, sorry, I forgot the last announcement, is at the end, we will do a question and answer and a discussion. So if you have questions as Dr. Greenberg is going through a presentation, please put them in the chat or in the question and answer box, and I'll make sure to collect all of those. Then we'll have a little discussion at the end. Awesome. So with that, Dr. Greenberg, I'll hand it over to you.
Thank you so much, Nathaniel, and thank you for having me, and excited to be here and excited to discuss Tourettic OCD and knowing sort of where things are generally, hopefully, you know, as you're watching this with your families, everyone's doing well with COVID, et cetera. So we're going to talk about Tourettic OCD, what it is and how to treat it. And in terms of disclosures, I have honoraria for speaking engagements. I don't have any conflicts of interest. I will be discussing treatments that are off-label, and many of the recommendations are based on a combination of research, research evidence, empirical support, and clinical experience. So in terms of the outline of the talk, I'm first going to talk briefly about OCD and tic disorders. I'm then going to talk about tics and their prevalence in OCD, then a discussion on Tourettic OCD, then differentiating tics from compulsions in OCD, and then finally some treatment suggestions. So briefly on OCD, it's now part of the obsessive compulsive and related disorders category, along with body dysmorphic disorder, hoarding, trichotillomania or hair pulling disorder, and skin picking disorder. And in terms of diagnostic criteria, it requires the presence of obsessions and or compulsions for either at least an hour a day or causing moderate distress and or impairment in functioning. We know that it tends to have a two-peak or bimodal onset, The first one is in childhood, often around average age 10, but ranges 8 to 13-ish. And then the other peak in adult onset, often late teens, early 20s. I'm going to focus more on the childhood onset part, or those with OCD. And what we know is that those with childhood onset OCD, there tends to be a greater genetic component to it, meaning more inheritable. And we know that it's associated with increased rates of tics and tic disorders. Different numbers are cited in different places, but often what we see and know is about 25 to 30% of individuals with childhood onset OCD also have co-occurring tics. And in general, the general population, OCD has a prevalence of about 2 to 3%. In terms of obsessions, which are intrusive, unwanted, distressing thoughts, images, urges that lead to anxiety, distress, or disgust, and common obsessions include worrying about germs and dirt, the contamination obsessions, feeling as though things need to be just right, symmetrical obsessions, worrying about bad things happening, being responsible for bad things, a sense of over-responsibility, and then intrusive thoughts, or disturbing intrusive thoughts, images about harm, aggressive, sexual, religious, moral themes. And compulsions are behaviors that the individual feels that they must do with the intention of getting rid of the unwanted feelings caused by the obsession, or to stop something bad perceived from happening. And often, even though we often think about fear as preceding compulsions, specifically in Tourettic OCD, which I'll get into, oftentimes a not just right feeling can also precede it, as well as disgust. So preceding experiences including anxiety, disgust, and not just right. Common compulsions include contamination, so washing, rewashing, confessing, over apologizing, reassurance seeking, touching, tapping, rubbing. I'll get a little bit more into that. Again, making things arranged, symmetrical, repeating until something feels just right. And then mental compulsions, mental checking, confirming whether or not one felt something, thought something, etc. And it's also helpful to characterize the OCD symptoms into subgroups. So these subgroups include symmetry, which often includes ordering, counting, rewriting, needing things to be just right. Forbidden thoughts, which is then sometimes divided into intrusive or taboo thoughts, and also into doubt and checking. And then cleaning and contamination, obsessions and compulsions. Hoarding was also originally a subtype, but now it's its separate diagnosis. And so now, shifting gears, I want to talk a little bit about tics. So what are tics? They are sudden, recurrent, non-rhythmic, abrupt movements and or sounds. They're somewhere between voluntary and involuntary. And so we sometimes refer to them as involuntary because, again, they're sort of in this in-between state. They tend to wax and wane over time. They tend to jump from location to location. And so they'll change both in location, but also in the frequency, the number that one has at any given time, the complexity, and the severity. They're often associated and or triggered or ameliorated by modifying factors, meaning that the environment, either external or internal, can either worsen or improve tics. And so often common ones are boredom, anxiety, even excitement can exacerbate tics. And then, being in a flow state or relaxed can often decrease tics. And they're often preceded by what we call a premonitory urge, which is described often as like an itch or a tension that's temporarily relieved by performing the tic. And so it's a somatic, a sensory feeling that precedes the tics. And then also sometimes it's described as a feeling of not just right or incompleteness, this premonitory urge. And so this is just a list of the different types of tics. We divide them into 2 by 2 categories. So there's simple motor and complex motor. So that means involving the muscle group. Simple meaning one muscle group is involved. Complex meaning multiple muscle groups. The complex tics can often look deliberate, though again, they're in that involuntary state in between. And then phonic tics, so ones that make a sound, and those can be divided again into simple, so sort of one syllable simple sounds, sniffing, grunting, throat clearing, and then into complex. And so that might be more like phrases, syllables. People often think of corpulalia. However, it's only in about 15%. Corpulalia is the swearing tic. And so what is Tourette syndrome? Tourette syndrome is a childhood onset neuropsychiatric disorder characterized by tics. And in order to meet criteria, it's actually pretty minimal. So the criteria for Tourette is at least 2 motor and 1 vocal tic over the course of the illness. They don't have to be concurrent. It has to be for at least a year, though the tics can wax and wane in frequency. And it has to be before age 18 and not secondary to a substance or medical condition. Estimated to be about 0.3 to 0.9, almost 1% that have Tourette. And then additionally, there's other tic disorders. And so there's persistent or chronic motor or vocal tic disorders, same criteria, except that only motor tics or only vocal tics, and that's an additional 1 to 2%. And then provisional tic disorder, and that is any sort of tic symptomatology lasting for less than a year. And some people actually theorize that it might be normal variant of childhood, as up to 20% of kids, especially around the age of 9, 10, will experience a tic that then is transient and ultimately goes away. So in this slide, I'm showing the circuit implicated in tic disorders, but as I'll get into, also in OCD. It's called the frontocortical striatal thalamo cortical circuit. So mouthful, but we could call it CSTC circuit. And it leads to dysfunction or disinhibition and dysregulation of these various processes, motor or movement. And so when that's disruptive, you might see tics, cognitive or thinking, that might be more of the ADHD, and affective or emotional, and that might be what we believe is more associated with OCD, also with reward-based processes. And so that's when we will sometimes also see in the circuit difficulties with impulsivity and compulsivity. And so this circuitry that's, again, implicated in tic disorders, OCD, and also, interestingly, body-focused repetitive behaviors, ADHD, etc., is implicated in forming habits, mood regulation, reward processing, and inhibition ability. And so you can sort of see the set of symptoms that one might expect to see clustered together when this is found to be affected. But the main takeaway from this is that the neurocircuitry of tic disorders, OCD, and ADHD seem to all associate with dysfunction in the CSTC circuitry. And so in Tourette syndrome, having a co-occurring disorder is the rule rather than the exception, with 85% of those with Tourette having at least one other condition. OCD and ADHD, as I mentioned, those are the ones most associated with that circuitry, are the 2 most common. Different numbers are cited for both, but generally speaking, one could say it's around 50%, with having either of them upwards of 70% and having all 3 probably about 30%. Also, even if you control for OCD and ADHD, we see with Tourette syndrome increased risks of anxiety disorders. And then separately, OCD independently associates with mood, anxiety, disruptive behavior disorders, so that's ADHD, impulsivity problems, substance use, and ADHD independently associates with the anxiety and disruptive behavior disorders. So you can see how comorbidity begets comorbidity in this picture. Mood, anxiety, disruptive behavior disorders, each about additional 30%. intermittent explosive disorder, so having behavioral outburst, tantrum, etc., out of proportion to the trigger, happening at least a few times a week, often associated with remorse, is seen in about 25% of those with Tourette, and anecdotally and less anecdotally research-based, also associated or seen more frequently than typical in OCD. Autism symptoms, autism spectrum disorders also elevated. And finally, again, BFRBs, body focused repetitive behaviors, trichotillomania, skin picking disorder elevated in those with Tourette. Also learning disorders, executive dysfunction, sensory oversensitivity. And that's all to say, so these are all the things that are often associated. That doesn't mean that everyone who has Tourette will have all these things. This just means that these are the things that we often look for when assessing someone with tic disorders or Tourette syndrome. And so now that we know a little bit more about OCD and Tourette, let's talk about the overlap. And so in Tourette syndrome, as I mentioned, sometimes the number of 50 is cited, but somewhere basically 30 to 60% will meet criteria for OCD. Often it's about 30% meet true OCD criteria, but an additional 30 to 40% might have obsessive compulsive symptoms. And so that's sometimes why you see such a wide spread of the number. But either way, that's compared to only 2% in the general population. So obviously a lot higher. In OCD, 30% meet criteria for chronic tic or Tourette syndrome disorder. And again, this is versus 2 to 3% in the general population if one combines all of the tic disorders. And multiple studies show a genetic linkage between Tourette syndrome or tic disorders and OCD since the early 90s. And interestingly, there are also certain symptoms historically associated with OCD that actually may be more genetically and clinically associated with tic disorders. These include the symmetry exactness symptoms and the touching, tapping, rubbing, and fear of harm. Similarly, aggressive urges that one often describes experiencing in OCD were shown to genetically link with OCD, but also with tic disorders and with ADHD. Also, they showed that tic-related OCD, meaning OCD with co-occurring tics, is in itself more similar to tic disorders than to OCD without tics, at least from a genetic perspective. And so, first question, does tic-related OCD differ from OCD without tics? And, there's certainly overlapping, and one can possibly have components of both, but the answer is yes, they are different. And what's interesting is tic-related OCD often associates with particular sets of OCD symptoms. So individuals with OCD and tics are more likely to experience symptoms in the symmetry and forbidden thoughts subgroups, and that's why I wanted to make sure to divide into those subgroups, less in the contamination subgroup. Obsessions are more likely to include, again, symmetry, aggression, intrusive thoughts, sexuality, religiosity, intrusive thoughts, and the compulsions are more likely to include checking, touching, writing, rewriting, evening up symmetry, and one of the most pervasive symptom descriptions is this feeling of not just right. The part that makes it a little bit complicated is we know that these are more common also in pediatric OCD, and pediatric OCD or early onset OCD is the one that's more likely to have the co-occurring tic disorders. So it's, I often think of it as early onset OCD with tics. There's, a significant overlap where the individual meets, is in both those categories. And so the term Tourettic OCD was coined by Charlie Mansueto in 2005. It can sometimes be confusing because the term can refer to both the broader set of symptoms often experienced by those with co-occurring tics and OCD, And it can also refer to a specific behavioral or compulsive symptom, like that's a Tourettic OCD or that's a Tourettic compulsion. Regarding the broader set of symptoms, it's often associated with male gender or male sex, earlier age of OCD onset, as we spoke about, and increased OCD impairment, early sensory hypersensitivity, attentional difficulties, learning difficulties, impulsivity, body focused repetitive behaviors, and increased anxiety and depression symptoms. And so as you can see, almost all of those that I just mentioned are implicated in that same circuitry, the cortical striatal-thalamocortical circuitry I mentioned earlier. Again, you don't have to have all of those, but that was when one saw the tics and the OCD, that is often the picture that presented. And also with these not just right feelings. So often people describe a sensory phenomenon or a feeling of incompleteness that's driving their compulsions. They state that it's not that they're afraid that something bad is going to happen or that something bad is happening. It's more this fear that if I don't do it, I'm gonna explode. I can't tolerate it. It's unbearable. I'm gonna go crazy. Those are often more what I hear. And then I'll say, well, are you afraid, because of that something bad will happen? No, it's just the feeling. And some studies, at least in the past, have reported limited response to fear-based exposures, again, because there's not necessarily a fear, and that it may be more beneficial to have more of an ACT or basically a distress tolerance approach in terms of the exposures. And regarding these broader set of symptoms, like very often those with Tourettic OCD have frank tics, though I could imagine that's not always observed to be the case. That said, if someone presents with this above symptom profile and the obsessions, compulsions more commonly seen in Tourettic OCD, I tend to think of them more from that framework, and we'll try to focus more on asking about tics, but it's certainly possible that an individual with this Tourettic OCD profile is not currently at least experiencing tics. And so then question 2, differentiating between tics and compulsions, does it matter? And so first, just to do a brief review on standard tic treatments. So we know that the behavioral, you might not know, but the behavioral gold standard for tic treatment is CBIT, or Comprehensive Behavioral Intervention for Tics. There are FDA-approved medications, although they're commonly reserved for those with more severe impairing tics. Given the potential for the negative side effect profile, we want to ensure that the cure isn't worse than the condition. Oftentimes, though, when one does want to initiate tic treatment, we follow the following tiered approach, where the first tier is alpha agonists, clonidine or guanfacine. They're actually blood pressure medications, and they have an indication for ADHD, but help those with tics maybe 30% of the time, about 30%, especially if there's co-occurring ADHD. The second tier is dopamine modulating agents, or also known as atypical antipsychotics, and some of these include risperidone, aripiprazole, trazodone. And then the final tier are also dopamine modulating agents, but typical antipsychotics, including haloperidol, pimozide, and flufenazine. In terms of standard OCD treatments, the gold standard behavioral therapy approach, as we know, is cognitive behavioral therapy, specifically exposure response prevention. And the gold standard approach to medication is with selective serotonin reuptake inhibitors, SSRIs. Some of those include fluoxetine, sertraline, fluvoxamine, clomipramine. Those are the ones that are FDA approved for OCD, but then also escitalopram, citalopram. Duloxetine is an SNRI. And sorry, clomipramine is a tricyclic, but is serotonergic. So what we know in terms of standard OCD treatment is that 2/3 to 3/4 of the patients improve with first-line therapies. But that said, there are certain factors that may make one less likely to improve, at least from a medication perspective, medication or therapy, depending on the factor. In terms of medication, tics are one of the factors. And so I'll get into that in a moment. And so again, question 2, differentiating between tics and compulsions, does it matter? So the answer is yes, because it can have a potential impact on treatment choice. So if one is presenting with impairing, distressing, taking a lot of time compulsions, and is presuming they're already in therapy, one would initiate an SSRI. However, if they're presenting with tics, and we wanted to use medication, one would initiate an alpha agonist or atypical antipsychotic. However, now there's these Tourettic OCD compulsions, the ones that might be in between or both. And so that might need a combination of OCD targeting and tic targeting treatment. And again, to the behavioral therapy, which I know Nathaniel can definitely speak much more about than I can, but at least some of the literature points to, if these compulsions are driven by sensory, not just right feelings, they may benefit from this additional distress tolerance component versus strict fear-based exposures. And so again, back to OCD and SSRI treatment, the reason it's important to know whether there are co-occurring tics in those with OCD is that it might affect the efficacy of the SSRI treatment. So the landmark pediatric OCD treatment study, or POTS, in 2004 showed that sertraline was significantly better than placebo for OCD symptoms in kids. However, when they looked at youth with OCD and co-occurring tics, and they compared those that took sertraline to those that took placebo, sertraline didn't outperform placebo. That doesn't mean that kids weren't helped. It just means that the group with sertraline wasn't statistically significantly better than the group with placebo. Important to note that behavioral therapy has shown to be equally effective regardless if there's tics or not. And so sometimes when SSRIs don't work on their own, and again, this is always assuming the person is in a good CBT ERP therapy, it's helpful to augment with an additional medication. The ones that have the most evidence are the dopamine, again, the dopamine modulating or dopamine blocking agents, which, not surprisingly, are the medications that are most effective in tic disorders. So again, you can see where all of the overlap is coming in. It's interesting to note that if one augments SSRI therapy in someone with OCD and no tics, the number needed to treat is 6, which is pretty good, meaning that on average, it'll take, if 6 people are treated with this, at least 1 will beat placebo. In comparison, if there is co-occurring tics with the OCD, the number needed to treat goes down to 2. So there does seem to be evidence that if one has OCD and co-occurring tics, augmenting with tic treating medication can be particularly helpful. One can also always consider glutamate modulating agents. Those are not FDA approved, they're off label, but do show some evidence that, again, that circuitry, glutamate is one of the neurotransmitters, which is why we think it might help. And then again, off label, but prior to using an atypical, depending on the symptom set, I might consider trying to augment with an alpha agonist. So again, those are the medicines that are used in the first line for treating tics and also used for ADHD. And so often if I have a patient that has significant OCD with tics and ADHD, and they're in good therapy, but still suffering a lot, I might try to add, again, off-label alpha agonist first, prior to going right to a atypical, or seeing whether I can reduce the dose needed of the atypical by also having an alpha agonist on board. It would be great if there were more studies on the future looking at this directly, because again, the goal is always to minimize side effects and optimize the treatment. And so in order to help distinguish between tics and compulsions, it can be helpful to ask what's driving the behavior. So is it more of a thought anxiety, or is it more of a feeling or sensation? So if it's in OCD, you might have the unpleasant thought, anxiety, the obsession that drives the compulsion. In tics, you might have this unpleasant feeling, sensation, or the premonitory urge that drives the tic. However, not uncommonly, there is something in the middle. And so this was actually coined by a patient of a colleague of mine, Dr. Sharves, many years ago, a tic-hulsion. And so that's when there's a thought anxiety that drives a tic-like movement. And then on the flip, a Tourettic compulsion or tic-related OCD or Tourettic OCD. And that's when one has the sensory, this not just right feeling driving the compulsion. I just have to do it. If I don't do it, I'm going to explode. I need to do it until it feels just right. So that's when we're often referring to Tourettic OCD or Tourettic compulsions. And so in my meetings with patients and families, I'm often asked to differentiate. And so one can use the strategies I previously mentioned, but it's also helpful to recognize that sometimes we just don't know. And it probably is somewhere in between, and it can be helpful to think of it that way. And in those cases, you know, it might benefit from one class of medication more than the other. That said, I thought it might be helpful to give an example of how I would try to differentiate between a tic and compulsion, and then I'll add in there impulse and disinhibition, because those are also often seen in this cluster of symptoms together. So compulsions, they temporarily relieve the distress caused by the obsession. So for example, tapping one's forehead to alleviate fear of dying. Tics temporarily relieve the distress caused by the premonitory urge. Stereotyped meaning it's the same every time. So tapping one's forehead because of the premonitory urge as a tic. Impulsion, so an impulse is so compulsion is the wanting to relieve distress. Impulse is failing to inhibit goal-directed behavior motivated by reward. So tapping start before one is supposed to in a race. So I think of impulse, can't stop oneself in going for something they want. Compulse, can't stop oneself from relieving something causing distress. And so then, and finally, disinhibition, which is a little bit separate from all of them, is more just failure to inhibit regardless of the consequence, acting without thinking. So tapping a button in the hallway because it was there. And finally, this is something that I authored with a few co-authors last year, following the study that Nathaniel mentioned, where I was working on a treatment for individuals with tic disorders and co-occurring ADHD, many of whom had also co-occurring OCD. And it was a symptom that a lot of them independently described that wasn't particularly well characterized in the literature. And so I sort of, at least currently, have penned it, given the name intrusive destructive behavior, or IDB. And so it's behaviors that are simultaneously deliberate and satisfying and also upsetting. And so this was observed in a subset of individuals with tic disorders, most often also with co-occurring OCD, ADHD, executive dysfunction, who felt compelled to perform certain behaviors despite the awareness of the negative implications. So they describe experiencing an intrusive thought of the behaviors that they don't want to do, and then an impulse, almost tic-like, to act on them. And so examples would include pushing on a bruise, if someone just built something, knocking down their construction, licking a dirty sink, making incorrect movement in a well-practiced sport. So I've had a few patients say that if they're swimmers, they'll, as they're about to win, they might inhale water. And again, like, you know, we speak about aggressive urges in OCD, we speak about non-obscene, socially inappropriate behavior in Tourette, but really, in this case, there is action on the thoughts in a way that does, again, feel satisfying, but also really, really upsetting to the patient. And the reason that it comes up a lot is because when I see this, oftentimes the parent or the teacher thinks that these are deliberate, on purpose. Is there a conduct problem? When in reality, the person really, really doesn't want to be doing them, but just feels like they can't stop themselves. And you know, working on treatments, but most likely involves a combination of education and then evidence-based treatment for the combination of tic, OCD, and ADHD approaches. And so finally, in terms of summarizing, we know that tics are common in those with OCD, about 30%, particularly those in early onset or childhood onset OCD. We know that Tourettic OCD or tic-related OCD comprises the specific symptom set different from OCD without tics, where we see more of the symmetry and forbidden thoughts subtype. And we also see increased prevalence of co-occurring conditions, including ADHD, anxiety, depression, impulse, etc. We can try to differentiate between tics and OCD by asking what's driving the behavior. Is it a thought, anxiety for OCD? Is it a sensation for tics? And it matters in terms of what medication agent one might use, but sometimes the symptoms are in between, and one might benefit from a combination. And then finally, just to reiterate, even though I did say that in those with OCD and tics, the SSRI didn't necessarily beat out placebo, SSRIs are still always the first line if you're treating OCD. For any one individual, that might be the case, and I might be a little more vigilant to try to watch for that and think I might need to augment, but still one should always use SSRIs in OCD, regardless of whether there's tics or not. And so thank you very much. And I look forward to questions.
Thank you very much, Erica, for a wonderful presentation. I'm definitely astounded by just in terms of like the level of comorbidity between the two, and kind of the relative focus in the field is still pretty new. I mean, new in comparison, given how many years it took to disseminate kind of ERP broadly as well. But that's definitely quite a high comorbidity rate between the two.
Especially in kids. And I think that's something that's right. And what we don't know is, or what at least I don't know is when one becomes an adult, whether or not that profile adapts, changes, morphs, because again, most of the, or at least the Mansueto group that they looked at, those were peds.
Mm-hmm. And that was actually kind of one of my questions that you beat me to, is the idea that I have seen a few adults that have kind of a Tourettic OCD or tics and OCD together. But it definitely seems to be in some ways almost like it's a little more prevalent in pediatric settings, and wondering if over time, are there certain tics that kids kind of grow out of naturally, or they're developmentally appropriate, and kind of in those cases, would it be something that you would necessarily do treatment for? Or do you kind of wait to see if they're going to grow out of that first? How might you approach that?
Oh, that's a great question, and deserves a nuanced response. And so I didn't talk about the clinical course of tics, but in general, they tend to get better as one gets older. There's some new literature pointing out that perhaps they don't actually totally go away. But in general, the vast majority of kids that have tics, it gets better towards their late teen, early 20 years. What we also, though, know is that OCD symptoms don't necessarily improve, even if the tics do. And so what I wonder, but again, another caveat to this is that we believe that childhood onset OCD has potentially a better prognosis in terms of remitting, either with medicine or therapy or just time, compared to adult onset. And so I wonder if there's a proportion of those with this Tourettic OCD childhood onset that improve, and then you get the second bump of the bimodal onset of those presenting with more of the typical contamination. And who's to say that someone can't have both?
Right.
And so then that's how you end up with like the different population over time. But regarding if and when to treat, with tics, it's if and when they are distressing or impairing. And so, it is a challenge, because you often say, like, yes, there's a good chance you'll grow out of it, but do we want to wait 2 to 3 years if one is suffering as much as they're suffering? Or should we do something now, knowing that it's not curative, but it might at least help decrease the symptoms?
It sounds like from what you described, too, even something as simple as like the enhancing distress tolerance skills could be just an easy kind of more general intervention, and probably arguably something that we should all probably learn more of in school than we actually do. It might be good to be part of the curriculum in general for all of us.
I completely agree. And I could like speculate about the role of like, instant gratification, social media, all of those things in I think potentially reducing distress tolerance. That would be speculation. But yeah, I think it would be wonderful if distress tolerance were taught more globally, because I do think that could just sort of bring down in general level of symptomatology.
Definitely. Well, and so if others have questions, please feel free to put them in the question and answer box or in the chat. So we do have one question so far that was talking about the circuit that you mentioned, that given how many disorders it's really implicated in around OCD, Tourette's, ADHD. The question was, are there cases where the diagnosis maybe isn't clear, but there are symptoms of kind of multiples of these disorders? And is anyone really focusing on the circuit rather than on the standard diagnosis? And if so, where would a patient find a kind of a treatment or someone to get a consult? What would that look like if the focus was more on that circuitry than on the diagnostic classification?
Yeah, I mean, that actually hits the nail on the head. I think there's probably different camps of practitioners, but I don't know if anyone listening has worked with me before, but what I'll often say is that it's sort of a disorder of the circuitry. So really what we should be saying is this is more like a CSTC, circuitry dysregulation syndrome, rather than all of these different diagnostic labels. I'll often say to parents, it's one underlying condition that's manifesting in these different symptoms, but really it's all coming from the same place. And so I'm at Mass General. I mean, that's how my group there tends to look at it. And so again, it's the challenge though is and so I'm really interested in better understanding that, studying that, figuring out if we could better treat it. Right now, our treatments are still tailored, unfortunately, to individual symptoms and quote unquote disorders. So again, it's the SSRIs for OCD, the atypicals for Tourette. So even though it still is that one circuitry, I think of it also sometimes like in like heart condition. So someone might have, like, generally speaking, like cardiac issues. They might have high blood pressure, high cholesterol, cholesterol in their atherosclerosis, problems with their arteries and stuff. And you end up on multiple different treatments, high blood pressure medicine, cholesterol medicine, et cetera, even though it's just one problem. So I kind of think of it like that, but I'll often refer to neuropsych treatment where I am. And so the, LEAP program, I work, anecdotally, I work closely with Dr. Colvin there, and she has a lot of specialty in that circuit. And so most of this I've sort of learned from her. And then, as time goes on, just seeing how much it applies. And so, yeah, I wish there were more people focused in that way. I think it's becoming more common as more people kind of, as the literature on the association becomes stronger and stronger.
And to add kind of from the behavioral standpoint, I think in many ways there's an element too of kind of what you were just saying, of you could almost take that neuropsychological approach of looking at it as like a perseverative issue in terms of how do you kind of inhibit it or how do you tolerate that sensation, no matter what the diagnosis is. I think that you mentioned the overlap with BFRBs, the body focused repetitive behaviors as well, where I could see there behaviorally be probably some overlap between helping kind of interrupt tics and kind of resist the tic style behavior or disengage from it once it starts, and also how we might approach things like habit reversal and kind of in like a trichotillomania or squariation disorder.
100%. And I think what they're also starting to look at now is the neuropsych profile, and whether like one of the components of that ends up being associated with the circuit. And again, I think there's still literature coming out on this, is cognitive rigidity. So having trouble set shifting, and just a lot of challenges with impulsivity, not being able to stop oneself from aiming for good, and compulsivity, not being able to stop. It's a lot of not being able to stop. no matter what it is, whether it's a movement, a thought, a feeling. It's a feeling of it moving more, faster, and harder to stop. And that sort of encompasses each of the different conditions. Another one, anecdotal, I think there's some evidence to it that I often now have been seeing more and more just clinically, is binge eating disorder. So again, it's which we know is associated with ADHD skin picking. I have a lot of individuals that cluster, again, anecdotal, that cluster in the ADHD, binge eating, skin picking, OCD circle.
Yeah, with that overlap, I feel like there's a lot of ways you can see kind of each of those symptom experiences kind of, at times may exacerbate the other. And one of the things that really stood out to me from your talk, when you were talking a little bit about kind of like the declusion kind of phenomenon, which I love that. And I think one of the things that I'd love to get your take on is, I know in adults, and this may be a little bit different, I've heard a lot of people talk about the idea that almost like sometimes the tic-related behaviors almost start the ritualistic compulsions. And then, and it's similar to what we see with sometimes with self-harm, but then even once that premonitory kind of experience is satisfied, then the OCD kind of like takes over, and it's like, well, I can't stop this until I get that just right feeling or that completion feeling. And then by the time they get that, sometimes that sensory experience almost like comes back, and you kind of get into this cycle. And you kind of mentioned the idea of like, does it really matter? Like the fact that it does matter how you differentiate them, both from a psychopharm piece and from like a presentation piece. Do you have any tips for people when they're trying to differentiate that piece of like, all right, maybe it's a little bit of both, or where does one start and stop, and then when does the next one begin, and how do I know what to do when that happens?
Yeah, no, again, like exactly. And I think, right, I think of it as mattering, potentially from the psychopharm perspective, but treatment wise, I think it also it goes back to that distress tolerance as being the common factor in both. And so I would say it makes total sense. And to me, like that description is both. It's tic and compulsion, and what to do. I actually, more for audience, I imagine this is similar to what you might do anyway, but one of the things that I was trained when I was trained in CBIT is just hit the first thing. So, if it could be the most complex tic in the world, if you get it at the first part, you're not going to get to the rest of it. And so in those cases, we would probably say, like, whatever that first sensation is, can you work on that through habit reversal, CBIT, ERP? In Europe, they use ERP for tics, actually. So it's, again, sometimes it's, is this a difference without a distinction? But that might be how I would think to approach it, knowing that it's always a lot more complicated than one would ideally want.
Yeah, definitely. That's great. Thank you. And so one of the other, let's see. All right. So one of the other questions that, making sure we got all the questions in here. If you have other questions, please feel free to drop it in the chat or in the question and answer box. Looks like one person does have a question. I see your hand raised. If you'd like, I allowed you to talk. So you should be able to ask your question this way as well.
Just chat.
I don't know.
Right. I don't.
No, should you?
Oh, can you hear us? Did you have a question, or would you like to type it in the chat and I can answer it?
Really?
Hurry.
Whatever.
Okay, got you. I see your question in the chat. So it sounds like the question was, should you try and stop the tic? Similar to how you might like to try to stop a ritual. Would you recommend that when you try to stop the tic once it starts?
I think, and let me see if I mean, I guess there's the yes, no, like as long, how do I get rid of that? All right, I'll stop share. And okay. Yes, using CBIT techniques. I would say, like, I think to say like, just stop the tic, that's part of the problem. If the person could, they would, or, if they want to, if they could, they would, but yeah, if one is trying to stop the tic, then I would recommend using CBIT, or habit reversal or ERP approaches.
Could you maybe give an example of like what that might look like, using kind of one of the CBIT approaches to intervene with the tics?
Yeah. So in general, there's 3 components to CBIT. So the first is the functional environmental component. And so that's assessing when the tics are most likely to occur, what modifying factors might be likely to increase or decrease the tics. So for example, if one has like a shoulder shrug tic and notices that it occurs predominantly when they get home from school after being in school all day and feeling restless, that's like the environmental assessment. And then you do an intervention, and that might be like run outside, run on a treadmill, do something that might just decrease that environment from causing the tic. So that's kind of area 1. Second area is the habit reversal component. And so this is similar, very similar to the treatment used in the BFRB's hair pulling disorder, et cetera. And so this involves first awareness training. So if one has a shoulder shrug tic, you often, this was told to me once, and I like this, you ask the person to describe it to you as though you were blind. And so it's what exactly are they feeling before it starts? And they might say like, well, I shrug my shoulders. Okay, well, how do you know when you're going to shrug your shoulders? And so, you go in like very, very, very small steps. Is it one shoulder at a time? Is it both? Do you feel it in your shoulders? Do you feel it in your neck, in your stomach? Is it a thought? And then you go into, you can train so that you do a little like, you can make it a competition, like, where the person raises their finger when they're doing it or before they do it, and seeing if they can, catch every tic, basically trying to build awareness. And then the competing response part, which is when you pick a response that is incompatible with the tic. So if it's shoulder shrug, you might pull your shoulders down. You can hold for at least a minute, and it's subtle. Because obviously you don't want the competing response to be more overt than the tic, because then that defeats the purpose. And so then you would, once you practice the awareness training, you would practice with the competing response when you feel it coming on, and even, sort of both in the moment, but then separately practice too in the same way. If you're playing a sport, you play the games and you have practices. And then the final element is social support, which is basically, and I think a reward component, which is often, again, I work with kids, but having parents work with the child in a way that's not nagging, because that ends badly for everyone, but it's more reminding, hey, do you want to use the CBIT? And if the answer is yes, great. If it's no, doesn't matter. But then, often having like a potential, when you do the treatment, rewards just for practicing, for trying, not based on the outcome, just based on the process. So if it was a shoulder shrugging tic, that's the CBIT approach.
Excellent. Well, thank you. I think and thank you for the wonderful question. I think that's probably a good question also to kind of wrap up on as we come into the last minute or two. One kind of final question I had is for anyone in the audience who's kind of looking for resources or kind of is struggling with this overlap between tics, Tourette's, and OCD. Do you have any recommendations of places where they can go for resources? Of course, we have the International OCD Foundation. I know there's an emerging number of resources on this overlap at iocdf.org. Are there other places that you recommend individuals go to kind of see both local resources or more tic or Tourette's-based resources?
Yeah, it is that, again, there's there's a lot of $1,000,000 questions. It's hard. I think twofold. One is Tourette Association of America. Definitely a really good resource. I think it's Tourette.org. And they go through all the symptoms. And then I think, it's at the risk of blowing us up, that's what we try to think about at Mass General. I work with kids. The Dr. Scharf is the director of the adult neurology tic disorders program. Right now, at least, it's more medication pharmacology focused. But I think what we really need is more people trained in CBIT, who are also trained in ERP, because then you could just use techniques from both. Again, you don't. It's not like it has to be one or that. It's sort of just more recognition of this sensory driven or not just right driven approach. And it doesn't mean the person has a fear and isn't saying it. It really means that it's driven by something that they just can't tolerate. And so I think we just need to get more resources, more research in it, more research on the treatments, and more dissemination of the treatments. But if we start online, Tourette.org.
Awesome, thank you. So we got we'll take one final question in the last like minute and a half. So we can give a quick summary to this question that came up is, in terms of speaking about how to differentiate between tics, self-soothing behaviors like stimming, and complex motor stereotypy, which is a kind of a variation on what you were talking about earlier on. And I think it's a really great question too, to add in like the self-soothing elements of it. Could you speak a little bit just to that question?
Totally. And so the best way I find to try to differentiate between stimming and more tics is twofold. Stimming is often self-soothing. So tics, again, getting rid of a negative. Stimming, not stopping oneself from a positive or something that feels good versus eliminating bad. And often stimming, it's repetitive. It's longer. Mm-hmm. So tics are quick, discrete, and stimming tends to be more stereotyped, longer, and more repetitive motions in themselves. I keep moving my hand because I'm thinking of rocking, or hand flapping. We think that it probably is also implicated in the same circuitry. So there's some evidence to that. So it's a good question and it makes sense. The medications, we don't have medications for stimming. Many people either grow out of it or learn how to tolerate it as they get older, but it's not infrequent to see all of these cluster together.
Is that, I noticed early on, you also mentioned one of the big ideas was that it's non-rhythmic when you're defining like a tic. Is that?
Yes,
exactly.
Yes.
Well,
non-rhythmic, yes, for stimming, and also seizures, in order to differentiate tics from seizures. That gets into a whole other topic because there's more functional tics that can sometimes look seizure-esque, but that's not a tic. But again, it's still involuntary. We just think it might not be the same mechanism that drives the more Tourette-based tics.
So maybe area for a future talk.
Exactly.
On this overlap, definitely.